This starts cardiovascular problems part 2. So the content we're going to cover is coronary artery disease, acute coronary syndrome, murmurs and irregular heartbeat, heart failure, and syncope. So for coronary artery disease, this is caused by atherosclerosis of the coronary arteries, which leads to restricted blood flow to the heart tissue. The restricted blood flow can cause angina or can cause a myocardial infarction. An angina is a restricted blood flow to the heart that causes chest pain, versus an MI is actual obstruction within the coronary artery or arteries that blocks blood flow to the heart, resulting in inadequate blood supply to the myocardium. So we need to know what are those modifiable and non-modifiable risk factors for our patients so we can screen who is it that's at greater risk and what things can we do to educate and help prevent coronary artery disease. So male gender, so males are more prone to having coronary artery disease. As we age, we're at greater risk. Having a family history or genetic tie to coronary artery disease and being of African American ethnicity are all non-modifiable risk factors. The modifiable risk factors is keeping blood pressure under control, so people who have hypertension are at risk. Those who smoke, those with a more sedentary lifestyle, those with hyperlipidemia, and women who are through menopause without any estrogen replacement, or those who are using oral birth control pills with smoking. What are some other contributing factors? So those who also have diabetes, who are overweight, and who have increased stress. So diagnostics. So anybody that comes in that's at risk, you want to get an EKG looking for any changes in the heart that could be indicative of coronary artery disease. You may want to get in these patients, especially those who are at greater risk, having them get an exercise EKG or a stress test. They can get a nuclear scan as well, sometimes doing a contrast with CT imaging, cardiac catheterization with angiography, intravascular ultrasonography, and high sensitivity C-reactive protein. Now, obviously, you're going to want to choose things that are least invasive and less costly. So getting an EKG, getting a CRP, those are things that we can do easily in the office to check. Patients who are at risk or have abnormals of those, then we want to refer them on to cardiology for that stress test and determine if they need further intervention. Management of coronary artery disease, obviously we want to reduce risk factors that are modifiable. We want to control symptoms, so if they're already having chest pain, we want to keep that under control with things like nystatin, put these patients on aspirin. We want to prevent the disease progression. So having them do lifestyle modifications, daily aspirin, those things that we can do to prevent progression of the disease. Sometimes they're going to need fibrinolytic agents. Sometimes for severe cases, they're going to need a balloon angioplasty or a stent, coronary artery bypass with a cabbage. Medications we can do is we can keep them or start them on beta blockers. If they have hypertension, to help control this, get them on daily aspirin, statin, nitrates. Patients who do need to have a PCI, within 1 year, they need to be on dual antiplatelet therapy, and below is listed. Remember too, as a primary care, we never want to stop these medications within that first year without consultation of the cardiologist. So then, once patients we know who have risk for coronary artery disease can get then to acute coronary syndrome. So this can be labeled as different types of angina. I do recommend you look and understand the different types of angina, what are the symptomology, so you can differentiate between a stable and an unstable, a variant, and then obviously a myocardial infarction. So patients who come in with chest pain, we always want to rule out acute MI with them. So we want to look for specific things. We want to differentiate between, is this lung, is this abdominal type pains? What are the pains actually coming from? Because chest pain not always means cardio. There's many other things that can cause chest pain. So knowing if it's from multiple sites, if it's actually from the chest wall, the lungs, the pleura, the esophagus, or is it psychiatric? Are they having, many of my patients with anxiety attacks will have chest pain as part of their anxiety attacks. We want to always think those and rule these out in the back of our heads. So other causes can be a PE, aortic dissection, tension pneumothorax, cardiac tamponade, mediastinitis or esophageal rupture, and then non-life-threatening things such as acid reflux, gastritis, esophagitis, and panic attacks. Okay, so these are the things we want to rule out whenever we're ruling out chest pain. So knowing also what are the symptomologies between these. How do you know if it's a cardiac versus an abdominal? Easy way to determine abdominal, non-life-threatening. Acid reflux is a very common cause of chest pain, but it usually radiates up the throat. It can be associated with food intake, usually, is a classic thing for acid reflux. So remember with acid reflux, usually it's after ingestion of food versus your H. pylori or your duodenal type ulcers pain. It's going to be that it alleviates, gets better when they eat food. So thinking about those type things that help you differentiate if it's cardiac, if it's pulmonary versus if it's truly abdominal or other symptoms. So to determine that, we want to get a good history of the chest pain. We want to know the onset of the pain. Was it abrupt or gradual type pain? Where's the site of the pain? Does it radiate anywhere? Is it diffuse? Is it localized? What about provocation and palliation? So what activated it, what made it worse and provoked the pain versus what alleviated the pain? What's the quality of the pain? Knowing if it's sharp, squeezing, pleuritic, they all have their own characteristics. So asking the patient, how would they describe it? Is it aching, throbbing, burning, sharp? Those will help you determine between the different types of chest pain. Does it radiate? Remember too, with radiation, you always want to look for the atypical MI, especially in females where it radiates to the jaw, the back, the shoulder, versus does it radiate to the throat? What's the timing, constant, episodic, duration of the episode? When did the pain begin? Was it associated with any things like food intake, nausea, vomiting, syncope, dizziness, palpitations? Those are going to help you also differentiate. Chest pain atypical of acute MI. So there are, like I mentioned, especially in female patients, they'll have that atypical type MI chest pain, which is more substernal compression versus the males tend to have that crushing pain. Pressure, tightness, heaviness, cramping, aching sensation can be described how the MI pain is. Unexplained indigestion, belching, or epigastric pain, it's not associated with that food intake. And it radiates the back, the neck, the jaw, okay? They also can have dyspnea, nausea, vomiting, and diaphoresis with this type of pain. Other important questions, what's their prior or recent cardiac testing? Do they have a history of high blood pressure? Family history of early cardiac death? Was there any change in activity tolerance recently? Were the symptoms with prior MIs if they've had prior ones? Any comorbidities like hypertension, diabetes, high cholesterol, those things that are going to, we know, increase their risk of having an MI. Any recent trauma, procedures, or travel. Any substance abuse, which is a key one to think about. Medication use and smokers. Okay. For the acute coronary syndrome or MI diagnostic, you want to get an EKG in the office. If you really do suspect MI, go ahead and get the EKG while you're calling to get an ambulance there. Go ahead and give the patient aspirin. If you work in an ER setting, you can get those cardio-specific like troponin levels or the cardiac enzymes. And outpatient setting, those are going to be worthless. You're not going to get the results back in time for them. And then you can also, many times they're going to get a CBC. They're going to get erythrocyte count, sedimentation rate, serum electrolytes, BUN, and creatinine levels. So those are the diagnostic workups. Like I said, outpatient, get the EKG, get them aspirin. If you're working in an ER, these are the type of lab work diagnostic you're going to order to rule out an MI. Next thing we'll talk about is murmurs and irregular heartbeats, which are relatively common. You're going to see these very often, especially in your geriatric patient population. So for history, you want to get a history of their cardiac, history of murmurs, which is kind of a key thing too. Find out before you even listen. Do you have a history of a murmur? So that way you know what to expect. Hey, this is a new murmur, we need to investigate this further. Get family history as well as their personal medical history. For physical exam with murmurs or regular heartbeats. Whenever you're listening, auscultating, you're going to get the timing of it. Is it S1, S2, is it S3 or S4? What's the quality of it? Is it crescendo, decrescendo? How would you describe it? Is it a sharp? The intensity of the murmur. So with intensity, we usually rate murmurs on a scale of 1 to 6. 1 being that it is very hard to hear, versus a 6 is audible with the diaphragm of the stethoscope. What's the location is also going to be important to determining where the anatomical irregularity is noted. Diagnostic workup, getting an EKG. If you suspect that this is related to an enlarged chest radiography may be helpful too. Getting an ultrasound / echo, sending them out with a new onset murmur. I always send them out to get an echo to look and see what's going on. They may need a stress test as well. Treatment, consider referral to cardiologist, especially if it's new or if it's somebody that has a murmur, you've noted it in the past, but now it's changed, it's louder. Getting them into cardiology for further evaluation. There are asymptomatic systolic murmurs, ejection murmurs, that's turbulent blood flow across the ventricular outflow tract. Usually they're described as a crescendo, decrescendo. They're medium top, low pitched, noted, heard best at the base. There's regurgitation murmurs, which is very common, especially for your patients who are aging. This is a issue with the valve. Many times it's the mitral valve, but can also be the tricuspid. These are usually high pitched. They're heard best at the apex or the medial sternal border, if I can talk. They are more of also a holocystic or mid-systolic late timing, and there's still that crescendo-decrescendo pattern to them. With the holocystic regurgitation mitral murmurs, it's the mitral valve incompetence that's causing it. It can be caused by secondary due to rheumatic mitral valve disease, bacterial endocarditis, dilated cardiomyopathy, papillary muscle rupture, or endocardial fibrosis, which would be secondary to finding out if they've taken medications such as fen-phen. For your late systolic regurgitation murmurs, it's mid to late systolic murmur. It's degeneration of the valve leaflets or the chordae, and these are late systolic murmurs may precede by a click that's noted. Older men may experience hemodynamic mitral regurgitation, and on EKG you might note nonspecific T-wave changes. For your ejection murmurs, early aortic and pulmonic valve disease can cause it. It can be caused by calcification of the aortic stenosis, aortic sclerosis. It can be idiopathic hypertrophic subaortic stenosis and arterial septal defects, which is one that they'd probably be born with too, so you're getting that history and knowing. For ejection murmurs continued, this is increased ejection velocity across normal valve, resulting in turbulence. Causes that can be associated with fever, anemia, pregnancy, hyperthyroidism, exercise, aortic regurgitation, bradycardia, like I said, an ASD, which many times they can be born with or it can be secondary to other things, hypertension, and just an aging process. So atrial fibrillation is kind of the big one that you want to catch too, which is more a irregular rhythm, and it's irregularly irregular, okay? Many times patients will present with a rapid heart rate. My patient that I can think of that I've had this, the nurse noted that the heart rate, they could not even count. Whenever I tried to count it, I could tell that it was irregular. The patient was having dizziness and lightheadedness and had a history of AFib. Many times also they can have shortness of breath and hypotension secondary to this. Diagnostic workup, get the EKG. This patient specifically, we got an EKG on them, noted it, got them sent out because of the fact that he was having other symptomologies with it. It can be secondary to hyperthyroidism, so sometimes getting a thyroid level, getting a BMP on them, chest, if they may be also having some chest pain with this. You might note jugular vein distension because of the tachycardia. They may have crackles, and they may even have an S3. Treatment, so you want to establish rate control. So if they are hemodynamically unstable, get them to the ED. Many times these patients will go home on either a calcium channel blocker or a beta blocker. They may need DIG, cardioversion, and also if it is recurrent or they cannot get them stabilized, sometimes they'll be started on anticoagulation therapy to prevent clots. Remember, with your AFib patients, these are the patients at greater risk for MIs and strokes too, due to that irregular pumping of the heart, that they can have stasis of blood into the heart, and that can cause clot formation. Next we're talking about is heart failure. So heart failure, risk factors is uncontrolled hypertension, those who have had an MI, aortic or mitral valvular disease, myocarditis, and dilated or hypertrophic cardiomyopathies. There are different stages and categories of heart disease. So stage A, they're asymptomatic. I have a patient who we caught this by chance. She had a murmur and we had sent her for an echo, and they noticed she was in stage 1 heart failure. She had occasional swelling, not very often. Her blood pressure was under control, so we're just at this point watching her progression and making sure that we can keep everything under control, lifestyle modifications. But otherwise, she's not really having any symptoms with it. Stage B, they might start having structural changes in the heart. They might be getting valvular disease secondary to this. Stage 3, they're more fatigued. They're going to have dyspnea on exertion. Pulmonary congestion on chest x-ray. These patients are having fluid overload. And cardiomegaly, secondary to the heart being overworked. Your stage 4, these patients are the worst stage off. They're having proximal nocturnal dyspnea, ankle edema. They will have jugular vein distension. They may have hepatojugular reflex, S3 noted, crackles, and pleural effusion. Diagnostic workup, getting a history. What's the family history? Family tie for heart failure can predispose them. Many times they're hypertensive patients that are uncontrolled for a period of time. For their physical exam, focus on cardiovascular, neurological, and peripheral. Many times they're having edema. So your hypertensive patients that start having swelling, you want to work them up for potentially heart failure. One of the easy ways to do this is get a BNP in the office. If it's over 100, that is a indicator of heart failure. Get them in for an echo and cardiology. EKG to look for that enlarged heart, and a chest x-ray. There's also functional classification systems, just like we had for the categories. So class 1, they're asymptomatic. Class 2, symptoms only with marked exertion. Your class 3, symptoms with moderate activity. And class 4, symptoms even at rest. Treatment, get these patients on an ACE or an ARB. Remember, we do not want them on both at the same time. Beta blocker to control if they're having any irregular heartbeat. Diuretics, definitely to get the fluid overload, so many times thiazides or loop diuretics for those who are having severe, and then severe cases will need DIG. Treatment, oral anticoagulation if they are having severe peripheral and at risk for MI or clot, many times starting them on aspirin, antiplatelet therapy, low salt diets, water restriction for fluid overload, daily weight monitoring, exercise training to get them to be able to exert and not have dyspnea and get some of the weight off, get them under control for their hypertension, diabetes that they may have, and then patient education, letting them know when they need to follow up. Many times these patients are also seeing cardiology at this point. The last thing we're talking about is syncope. So syncope is a reversible loss of consciousness. It's transiently insufficient cerebral perfusion. Presentation, patients will have either loss of consciousness or near loss. with dizziness and feeling faint. There's many reasons for syncope. It's not always cardiac, but sometimes it can be secondary to arrhythmias or PE. It can be neurologically mediated, such as vasovagal or situational, and then cerebral vascular, CVA, seizures, and metabolic. So for history, finding out, have they had history of syncope in the past, history of near passing out, any cardiovascular, neurological, or other history, physical exam focusing on those 3 areas, and then you will get an EKG on them. If there are some concern for cardiac rationale for it, get them in for a stress test. They may need a heart monitor, especially if they're having palpitations or you notice any murmur, irregular heartbeat. Getting a BMP, looking at electrolytes. Consider H. pylori too for blood loss that could be causing this, or infection. And it could also be secondary to orthostatic blood pressures. So getting, in office, getting orthostatic blood pressures, looking and seeing if they're one, especially if they're a hypertensive patient, maybe their blood pressure is better controlled and we have them on too high of a dose and it's causing syncope. So we want to watch for those things. Treatment, determine the cause. We can't really treat unless we know what's causing it. Treat appropriately, consider referral if they're a person who's having irregular heartbeat, murmurs. Maybe they need to get into cardiology, look at an ablation. If it's GI, easily treat. If you suspect H. pylori, treat that in office. If it's psychological, get them, in for referral and neuro as well. That's the end of our second part of cardiovascular problems.